Neuro-Urology. I'm a fully trained urologist since 1998. I was trained in the University of Aachen. I was in the States where I'm right now, 95 to 97 on a German research grant. And I was a university professor of the University Clinic in Bonn, and I led 2 neurourology clinics, one at the university and one in the Johanniter. And I retired this July, but I like teaching. And as Abhinav already said, my great passion in the moment is establishing neurourology in Ukraine. But I'm really happy that we all are supported by Medsynergy and by INUS. INUS is the International Neuro-Urological Society, where Dalish Panika, who gave an excellent first course on basics of neurology in the beginning of this summer course, and he is head of education, and he asked me to join to prepare for this course. And thanks to Abhinav and Christina, I think it has been a wonderful experience so far. So, next slide. Yeah, I'm now on slide 3. So first of all, for all those who are very ambitious and have seen all lectures or heard all lectures, some will be repetitions. But as I know from Abhinav, some of you also know. So before I start to actually go to treatment, and it's really the basics, I want to really make sure that we all know what we are talking about. The aim of neurourology, and that's the beauty of neurourology when I think of it, is prevention. First of all, we want to preserve renal function. We want to prevent urinary tract infections. We want to achieve sufficient bladder storage, and if possible, restore continence. And of course, we want to improve quality of life. So next slide. So when all of us think about the bladder, we all think of, at least that's my experience, we all think of having to go to the toilet and pee. But basically, 95% of our time, hopefully, we are not spending our time on the toilet. Our bladder is a calm, leaving us alone storage organ. We, of course, have the perception when we should go to the bathroom, and hopefully we are able to empty the bladder in a comfortable way where nobody is looking. 5th slide. So what's happening with the bladder in the storage phase? The detrusor muscle, so that is a muscle, the smooth muscle which actually provides the action in the bladder, it relaxes. And the sphincter, because we don't want to leak, is contracting. The normal storage capacity is about 400 to 600 milliliters. It depends a little bit on age. So when you're over 17, it probably decreases a little bit. Perception of the filling stages is, you might know that there is something in the bladder at 200 to 300 ml. And in most cases, the first urge to urinate is 300 to 400 milliliter. Next slide. There is a contraction of the detrusor. That's, of course, when we want to void. And, of course, then the detrusor contracts and the sphincter relaxes. What we want is a low resistance emptying. Why that's important is, of course, we want to keep the pressures in the bladder down. We want, of course, empty the bladder completely. And we want it controllable. We want to pee when we want at a place where we want. Different to baby, right? So when we know about the function, we also know about the dysfunction. There can be a dysfunction of the torus function on the level of the detrusor. Then we have an overactive and small capacity bladder. Some young women have it, they always feel the urgency of voiding. That goes away after a couple of years. And of course, in elderly, we often see an insufficient bladder closure. That's when they leak. The voiding dysfunctions can be described as if you have a large overstretched bladder, a tonic, hypotonic detrusor. We see that in some patients with a lower spinal cord injury. Of course, we have also a voiding dysfunction in men with an enlarged prostate. We have an functional anatomic intravesical obstruction, and we can have a functional intravesical obstruction by having a detrusor sphincter discoordination. We talk about a detrusor sphincter discoordination when it is non-neurogenic cause, and we speak about a detrusor sphincter dyssynergia when the sphincter contracts and the detrusor contracts simultaneously and not in a coordinated way. That, of course, is a very severe condition, and we hear more about it in the following slides. 8th picture. And I think now in all our talks, the first by Panecker, who is one of the authors for this slide, then also with Helmut Madersbacher, and also Glenn Wenworth pointed at this slide because it's so important. Because remember, it's all about how big is the risk of renal failure. So, and there are, if you want to know more about how exactly the bladder is controlled by the brain and the spinal cord, I really advise you to listen to Dallas Panecker's talk, which is on YouTube. And so, and when we look at the lesions, we have suprapontine lesion that's above the spinal cord. And this lesion is predominantly storage symptoms. So they have sometimes, so they leak all the time, but they don't have residual urine. And if you do urodynamics, that means a functional testing of the bladder, you will see a picture of detrusor overactivity. Just to make it more easy to understand, that is basically not a lesion, but it is a situation a baby faces. The baby has no problem voiding. The baby doesn't only know when and where it is appropriate to void. So this is equivalent to a suprapontine lesion. And Helmut Madersbacher formed these little normograms where it's then easy to understand. It's an overactive detrusor and a normoactive sphincter. The causes of such suprapontine lesions: head injury, encephalitis, dementia, Parkinson, stroke, and some cases of MS. Now the next group of patients, and you see on the left side, the risk for renal failure is here the highest, are the spinal infrapontine suprasacral lesions. And they face both storage and voiding systems. In the ultrasound, sometimes or often p-VAR is unusually high. And in urodynamics, you see a detrusor overactivity and a detrusor sphincter dyssynergia. And let's look at the Madersbacher normogram. You see now a thick bladder having, symbolizing the overactive bladder, and having a thicker 2 dots representing the overactive sphincter. And this is the case in paraplegia, spinal cord injuries, and in many patients with multiple sclerosis, actually in most, but not in all. And then the last group of patients we're talking about are those with a sacral, infrasacral reason. And you see that the risk for renal failure becomes smaller. So there's less risk, but still those patients need help, and they're not happy. So predominantly, they have avoiding symptoms. As they have difficulties voiding. They have often a very high PVR, residual urine. In urodynamics, we find hypocontractile or acontractile detrusor. And you see the same, the normograms, which now is thin line representing an underactive or a no active detrusor, and the sphincter can be normoactive or underactive. This is the case in cauda equina injury, in pelvic trauma, and you have to know that extensive surgery in the pelvis, like for extended hysterectomy with ovarectomy, for intestine carcinoma, or also in diabetes mellitus, where the peripheral nerves are affected, you find these kind of lesions. So I'm now on slide 9, and you see again a summarize of what we already said, and you see that it's a great way of getting an overlook. You know, what is a detrusor and what are the sphincters doing with the spinal, lumbosacral, suprapondine, lumbosacral, subsacral, lumbosacral, sphincter only. So you get a feeling that this nomogram helps you to get a basic understanding of what kind of lower urinary tract dysfunction you have to expect. Saying something about the words, we used to say neurogenic bladder. We kind of abandoned this term because, as you see clearly, it's not only the bladder, it's also the sphincter affected. And so now we speak about neurogenic lower urinary tract dysfunction. We're on slide 9. And the big difference is the upper motor neural lesion affected? That means is a central nervous system directly has a damage, or is it only the cauda, conus cauda, and the lower motor neuron? But you see also by this picture that you can't determine it only by how the level is, it's TH12 or L1, L2, because the fibers descend the spinal cord much earlier, and so you need further investigation. So diagnostics and treatment depend on the risk of renal failure. So, and this is the golden standard, it's urodynamics. And since all treatments based on urodynamic findings, I will shortly tell you, and that's why it's so important for me to bring urodynamics into Ukraine. And I'm really grateful that we make, thanks to international, national, and of course, Ukrainian help, a lot of progress. So a neurogenic detrusor overactivity. This is typical for supraspinal reflex bladder. The spinal reflex bladder, and this is the one we are talking about when it comes to treatment. And you see the X-ray on the right, and that's a picture we don't want to see. Remember, neurourology is all about prevention. We don't want to see a reflux, and we don't want to be a Christmas tree-shaped bladder with all the diverticula. But if the pressure in the bladder is high, even without a reflux, the kidneys can't work properly. So we have to reduce involuntary contractions, we have to protect kidney function, and we have to improve the quality of life. And I don't know if everybody is familiar with urodynamics. So just a short way, and I know that Glenn also talked a little bit about urodynamics. It's putting a catheter in the bladder, kind of the blue line, putting a catheter in the rectum is a red line. And then we have two pressures, and by subtracting the abdominal pressure from the vesical pressure, as a result, we have the detrusor pressure, and that's the pressure we are concerned about. That's important to know.
Oh, sorry.
Are there questions? Okay, then I continue. Like this is a typical picture of a detrusor, phasic detrusor overactivity. So this is a vesical line. The blue line is a vesical line. The red line is the abdominal pressure, and the subtraction of the abdomen to the vesicle is a detrusor line. And now we see high pressures, and I don't know if you see, but they must be about 100 centimeters of water, and this may be 60, 70 centimeters of water. And below is a line where you see kind of purple. You see, you could say voids, but they are not really voids, they are leakages. The pressure is so high that the urethra leaked. This is an uninhibited detrusor contraction with a leak. So now we are on slide 18. Another way where the pressure can develop in the bladder is just by it losing its ability to extend. And then if it loses its ability to extend, the detrusor pressure increases with filling. And that's what we call a so-called low compliance bladder. And everybody who was there for the last week's test from Glenn Werneberg knew how to calculate the compliance by dividing the flow the volume difference by the pressure difference. And this is a typical picture of the detrusor sphincter dyssynergia. Is involuntary contractions on the bladder muscle. You see this in the red dots, and a non-synergic voiding, and you can see that easily also in the X-ray, where you see the dilated proximal urethra, and then the sphincter closes and only lets urine out in squirts. So slide 20. This is what high pressure can do to the bladder. It's a reflux, but remember, the reflux is a worse sign, but the kidney is already harmed even if there is no reflux existent. But you can see here the dilated proximal urethra during voiding, and there is no urine coming out. And on the other picture, you see how the pressure involves all the, it gets to all these diverticular. And we call this Christmas tree formed bladder. We don't want to see this. I have to admit that children are an exception. In most cases, these damages are not reversible. So now we come finally, what's the main topic of our talk today is how do I therapeutically deal with a neurogenic detrusor overactivity. And we all know, like always, you start low and aim high. So you normally start with behavioral therapy, then you add medication. To inject botulinum toxin would be more invasive. Sacral modulation would be even more invasive. Then the spin-off electrical stimulation of the peripheral tibial nerve system is not so invasive. And of course, the most invasive treatment is bladder augmentation. Next, I go to 23. I start with behavioral and conservative approaches, but only to tell you that this is in 90% of all neurogenic patients not feasible. It's only feasible for selected patients. Maybe patients with multiple sclerosis who still have a sensory feeling of their vagina or their pelvic floor. And you have to, in the women, you have to do a vaginal examination to see if they have some sensation of the pelvic floor left. And it's not the preferred, it's not a method at all for a complete spinal cord injured patients. And for most patients with a neurological detrusor overactivity, time voiding, prompted voiding, pelvic floor muscle, limited fluid intake, avoid diuretics are not feasible therapeutic options. But of course, in patients with incomplete lesions, low lesions, all these advices may help. And of course, if there is leakage, we have to use absorbent products as needed. Most of all, the therapeutic choice, or the first therapeutic choice, is using medication. So, and this will be an important part of my talk. So, but let's go back to the basics again, because, you know, everybody has a different level of knowledge, and I excuse if this seems too basic. But we know that the autonomic nervous system controls the sympathetic nervous system and the parasympathetic nervous system. And due to our evolution, it made sense that when we have stress, adrenaline rises. The sympathetic nervous system, which is controlled by the hypogastric nerve system T10 to L2, it inhibits micturition. See, if somebody wants to eat us up, it's better not to have to void. Very different. If we are calm and rest, we can digest. The parasympathetic nervous system takes over. The pelvic splenic nervous system is controlled by the spinal micturition center S2 to S4, I'm sorry, and that provides micturition. We go to the next slide. And when we know the mode of action, just the opposite is the mode of treatment. So on the right side, you see the mode of action I just explained, and to the on the right side, you see the mode of treatment. Let's start with the parasympathetic, the cholinergic control. We give antimuscarinics. You have to go with a, yes, we give antimuscarinics, and these block the receptors, and that inhibits the involuntary contractions, so we can delay our voiding. And on the sympathetic arm, the adrenergic control, we use beta-3 agonists. Most known as mirabegron or as Betmiga. They increase storage capacity and intervoid interval. Next. So antimuscarinics is the first line of treatment that is been long on the market. Everybody probably knows oxybutynin, and there are some newer projects like solifenacin and Vesicare. They block muscarinic receptors on the bladder muscle. They reduce involuntary contractions, but they are accompanied by a lot of common adverse effects. Some include dry mouth. You can treat them maybe with a sugar-free gum to chew on. But the most adverse effect also affects the intestines. Patients suffer from constipation and also from blurred vision, but I want to concentrate on constipation because you have to know everybody who's suffering from a neurogenic bladder might also have a neurogenic intestine, so you always have to take your medical history not only on the bladder but also on the intestines, how your bowels are. Beta-3 adrenergics are, as I already told, the new kind of medications. They are in the moment second line. They are widely in use already, although they have not entered all guidelines yet. They relax directly the bladder muscle. They can be used alone or in combination with antimuscarinics, mainly to reduce side effects or to get more efficiency. but they also, of course, are not without side effects. They increase blood pressure, can cause headache, and rare cases of urinary retention. That is not our main problem because, as you will know later, nearly no patient with spinal cord injury can really void naturally. And a lot of patients with MS eventually have to return to getting a great bladder storage organ and then do the micturition via catheter. So, but we have to know that, of course. So next slide. Kind of a summary. And that's from all the guidelines I looked over. I looked over the European guidelines, American guidelines, and the Canadian and the German guidelines. So it seems that combining antimuscarinics with beta-3 adrenergic agonists yields greater symptom reduction than a monotherapy, but we still should start with antimuscarinics. If available, use extended release or transdermal formulation to reduce side effects. Actually, the transdermal formulations haven't really made it. So I think they are and I know they are not available in Ukraine. At least that's what my last informations are. And what's more severe is with antimuscarinics, there have been data about cognitive impairment in elderly patients. And although it's so long on the use, we don't really know if it doesn't also affect the cognitivity in younger patients. We have to monitor the side effects, and I already stressed out especially obstipation. And of course, if they don't have a catheter or do catheterization by themselves, we have to monitor residual urine. But let's say that again, in patients with high detrusor overactivity, with pressures over 40 centimeters of water or less, but in a frequent time, most important is to keep these pressures down, because otherwise we risk renal function. So, and there is a new way of delivering antimuscarinics. It's not really new. When I started my training as a urologist in 1889, but already in the 90s, we would teach parents with kids with spina bifida who can't swallow because they are too tiny, who can't swallow a pill. We taught them how to crush oxybutynin in a, crush it in a like a spice, and then fill it up, dilute it in NaCl, and then they would give this dilution through a catheter into the babies. So this was in the 90s, and then pharmaceutical company thought of a better way of doing it, and it took them over 10 years to finally get an end product approved, at least in Germany and in Europe. So now we have a diluted oxybutynin where you can put directly in the bladder. Again, it causes less side effects than the orally given oxybutynin. And I hope that we succeed in also introducing intravesical oxybutynin in Ukraine. So slide 30. And what I already said, in this respect, in nearly all respects, all the guidelines really agree. And I know in Ukraine, they like to turn to the Canadian guidelines. And the good thing about the Canadian guideline is, and you can very well copy this link, it has a proven English-Ukrainian translation, which might be very helpful, at least for those who work in Ukraine. And I'm very grateful for that. And I think Andrew Krasikov was a main driver of this, and I'm very thankful. So let's come to botulinum toxin A. I have to admit, when I first introduced that, I asked, the first doctor I identified in Ukraine who was dealing with spinal cord injuries. I taught him how to use a urodynamic machine. He had a urodynamic machine, but it didn't work, so we got it to work, and he doesn't do it. And then I said, do you also have access to botulinum toxin? He looked at me as if I said, have you seen the green min from the Mars? So, but now I know that botulinum toxin is available, not so much for the neurogenic patients I wanted to, but for me, the botulinum toxin was a game changer in treating patients with spinal cord injury. And I think approximately 50 to 60% of our SCI patients today get botulinum toxin. It's basically, it relaxes the detrusor because it's a nerve toxin, but has very little side effects. Besides that, you have to repeat injection every 6 to 9 months, and we have to work on the availability worldwide. So. And only to tell you, I think we used it in our clinics nearly 10 years off label before it finally got authorized in 2011. And that was due to the work of Manfred Störer, a good friend of mine, and Mrs. Schurch from Switzerland, also a very good friend of mine. And I knew how much they fought to get it really approved and acknowledged, but now it is acknowledged. It's acknowledged also for detrusor overactive without a neurogenic cause, and it's allowed to be used for patients who don't respond to medication or who can't bear the side effects. And of course, it's best used for patients capable of single-use catheterization, because after Botox injection, at least in those with spinal cord injury, they have to do intermittent catheterization. And you shouldn't do the procedure when acute urinary tract infection is there. So, and you see here a nice picture of Manfred Störer before and after injection, and you see that the diverticular are gone, the reflux is gone. But even if you don't see those morphological signs, again, if you see urodynamically detrusor overactivity and you can't treat it with antimuscarinics or with mirabegron, then you should go to Botox before you see those morphological changes. Next one, we're on slide 34. It's a sacral neuromodulation. So that's second line or third line therapy after medication and Botox. But in SCI patients, it is experimental when their lesions are complete. If you don't see any in the urodynamics, any detrusor action, it's useless to try neuromodulation. If there are no neurological impulses, you can't modulate anything. But there are data that sacral nerve stimulation in MS and other neurogenic lower urinary tract dysfunctions can be useful, maybe also as an adjunct. And the AUA guidelines, it's level C of evidence, so much more research is needed. And I know Andrew Krasikov from Canada is working on finding a group who does research with him on the ways of doing sacral modulation also in spinal cord injured patients. But up to now, it's experimental, and it can be only recommended for selected patients. And I would rather see it within studies. So a little bit different is electrical stimulation, the peripheral tibial nerve stimulation. We go to slide 37, and here you see a picture. The peripheral tibial nerve stimulation, the tibial nerve close to the ankle. You see that on the foot down there. And this stimulates the posterior tibial afferent nerves and then goes to the spinal cord and then modulates the bladder nerves. Closer and I think more reliable is a direct sacral modulation, but this has to be done by an implant. And whereas peripheral tibial nerve stimulation can be done in an ambulance service, stimulating either with a needle or with a patch the tibial nerve. So, and last but not least, I want to talk about the last way of helping to keep the kidneys around. When everything has failed and you saw the patient too late, it was already has already a kidney is shortly before losing the kidney, then you might think of bladder augmentation. And I won't go into the surgical procedures. You can either do a cystoplasty so that you remove the bladder and replace it with a bladder made of intestines, or you make a bladder augmentation, leave part of the bladder, but you have to make sure that you take off enough bladder so that the detrusor overactivity doesn't kick in again. Last reason. But now we have talked all about neurogenic overactive bladder. But as we saw, this goes with the upper motor neural lesions. But of course, many patients, about 50%, or it depends on where you are, have a lower motor neural lesion. That means their sacral nerve system is not intact, so they can't void. They have a detrusor underactivity or even atonic bladder. So what are here the options? Slide 41. So this now deals with sacral lesions, with infrasacral lesions, like polyneuropathy, diabetes mellitus, or extensive surgery in the pelvis. Our treatment aims are, again, we want low pressure, emptying the bladder. We want to protect the storage function, because if you always overextend the bladder, you also lose storage function. And we want to reduce the risk of urinary tract infection, which is anyhow the most problematic aspects in patients with bladder dysfunction. And of course, we want to improve the quality of life. So we speak of a detrusor underactivity if there is an insufficient or no contractions of the bladder muscle due to neurological conditions. So, and this is the picture you see in urodynamics. You see no detrusor action at all. So you see basically a flat line. I can tell you the quality of the measurement is good. You see these little spikes, they are coughing. Both coughs are produced, but there is the coughing. And sometimes, and this is nice that IVANO shows us sometimes coughing in patients with a lower motor neuron lesion have very low cough spikes. But you can still see that they are there, but there is no reaction of the detrusor. These are the subsacral or lumbosacral lesions. Next slide. So again, what can we do? Catheterization, medication, behavioral treatment. 44. Unfortunately, the main treatment option is catheterization. I know that's hard to believe, but up to now, and that's again another great research field, Glenn Wernerberg also mentioned, it's developing a drug which increases contractility. So, and also the Canadian guidelines clearly state that triggering or Valsalva, or, you know, that you press the bladder or use enormous abdominal strength to empty the bladder, that is not a good option. It increases the pressure in the bladder. It eventually will risk the health of your kidney. And the clean intermittent catheterization is a preferred method. And there are different methods. There are reusable catheters on the market. And if you live in a country where you have, because of budget issues, have to use a reusable catheter, I would try to find a catheter on the market which is designed for reuse and take their ways of how to clean it. So we do the intermittent catheterization mostly 4 to 6 times a day, mostly 4 to 5 times. We try to teach them not to use to have more than 400 ml in the bladder. And you insert the catheter through the urethra into the bladder and allow the urine to drain out. And once the bladder is emptied, the catheter is removed and the person stays free from the need to wear a catheter. And, you know, when I first tell this to patients, they're very shocked. And I see also a lot of MS patients who eventually gain a lot of quality of life. If their bladder dysfunction becomes worse and worse, then they really gain quality of life in replacing micturition by intermittent catheterization, because then they don't have a catheter. And I don't have to tell you, young folks, that it is really limited for, the doorbell is ringing. That's not a good sign. No, wait a minute, I don't know. So I will continue. So, and this has to be trained. The training of clean intermittent catheterization, we have a whole bathroom for is, you have to take the fear of doing intermittent catheterization of the patients. I already said preferred whenever possible, but the first thing neurourologists do, they look at the hands. And of course, if the dexterity is not sufficient enough to use a catheter, no use. And of course, there has to be the compliance and also the cognitive skill to do it. Then I always tell the first 6 weeks, they hate me. And after the 6 weeks, when they see that their quality of life is really better, then they love me. And of course, if we have to use an indwelling catheter, we prefer a suprapubic catheter over a transurethral catheter. Medication. Of course, that's what I already says. There is no proven sufficient treatment. And I told you already how long it takes to get something to get into the guideline. And I tell you, it takes at least the time to get something out of the guidelines. And theoretically, it would work, but it's in the neurogenic, in the neuro-urology societies, it is not recommended any longer. So don't bother people with medication which don't work and will have side effects, and you lose time. And especially in patients we are several times discussed, in the patient with an upper motor neural lesion, with a detrusor sphincter dyssynergia, it often takes only 5 to 7 years until you lose the kidneys. You lose the kidneys, so you don't want to lose time by using medications you don't know they have little or no effect. What about reducing bladder outlet resistance? That would be theoretically the other approach. And you can do it with alpha blockers in women, but also cautious in selected cases. It helps sometimes if patients have difficulties catheterization, but if they can't void at all, alpha blocker won't change that. If they void with if the residual urine is kind of borderline, you don't know if you can accept it or not, try it. Give you a certain time and try it. So next is behavioral treatment. And unfortunately, here again, there is a limited space. I'm a fan of pelvic floor muscle training, but I know it takes a lot of time from the patient, from the physiotherapist, and you should really only do it in patients you think you will have success. And you have to see if they have some sensation of the pelvic floor. And in patients with spinal cord injury, it's only recommended in motivated patients with incomplete spinal cord injury, AIS, C, or D. Or in some patients with multiple sclerosis, whom you can test, because main populations are women, you can test if they can have some feeling of the perineal or the vagina. So next slide. Always remember the treatment goals. I feel like a preacher. Protection of the upper urinary tract, pressure reduction in the lower urinary in the bladder, preserve the bladder function. And even if you think, you know, oh, we can also transplant, or we have dialysis, transplant and all, they doesn't transplant kidneys will be destroyed as fast, quicker than the original kidneys. So to do a kidney transplant with the bladder with high pressure is a waste. It doesn't help. Maybe months. And preserving the bladder function helps letting the patient be independent. And of course, we can work on the storage function as long as we ensure the pressure-free emptying of the bladder. And that is the best way of avoiding of infections. Regulated bladder emptying is not the main goal, but of the normal micturition. Of course, regulated bladder using the catheter is a main way of achieving our goals. I want to thank you for your attention. Of course, I want to really thanks to Medsynergy and the great organization by Jalish and Abhinav and Christina and everybody who is involved, and for the support of INUS. And I can tell you what Jalish already mentioned in his first talk, that everybody under 34 or under 35, I'm not so sure, can join INUS for free. And it's a worthwhile organization. It's a very young organization. It's open for research and for lectures. The next meeting will be in Jakarta. So maybe for some of you, it's closer than for me now in America. And I'm always supported by a Continence Research and Education Association. I already founded 2006. And if you see the lovely ladies on the right of the raising pictures, they're Irina Godima and Irina Rodenko. The two join me when I'm traveling Ukraine. They are both from Ukraine and they speak Ukrainian language, and that makes my trips easier. And I was glad that I also could meet Abhinav in person. Thank you. Thank you for your patience.
Thank you so much, Professor Ruth. It was a very insightful lecture. It was great to know.
And you see me, if you want to, you see me next week. And then I'm joined by Professor Dr. Kadir Onem, and we try to discuss some real patients.
Yeah, it was a very good lecture. So we have some question. If someone has question, please raise your hand. And we have a question in chat also. So I will answer. So it was question from Naveen Vadnapau.
Yeah, I can see it in the chat. He asked, what caution do I need to take, consider while prescribing, or any specific red flags or contraindication? So it's, of course, high blood pressure. It is cardiac I would say, as a urologist, any cardiac problems, you should discuss it with the internist if you should go to mirabegron. Are there any medications studied? Definitely. I think it would be a huge market for the industry, and they're definitely studied, but none of that, I think, now in phase 3 trials. So there may be something in animal trials. I know that they're working on that because I think 10 years ago, I already thought it was shortly before we would see a medication, but then this vanished again. So I don't know where it is at the moment. I have the feeling that Glenn Werner would know more, and that he might be closer to medication research. I'm closer to the electrical stimulation research, and there is another treatment option which unfortunately can't be maintained really unless you are in Colombia. It's like cutting the afferent nerves and then stimulation the afferent nerves. And there was a so-called device as a Brindley device on the market. And whoever has questions to the Brindley might very well contact me or contact Abhinav, and he'll get my this. And that is something which will be discussed also at the ISCOS, the International Spinal Cord Injury Meeting, this October in Gothenburg. I will be there. And that is something I see more easily happen, but you know, with pharmaceutical research, I'm just too far away. I'm a basic urologist, clinician, and researcher.
Yeah.
Oh, there's
So
another very, yes,
yeah,
I
they have
see.
many questions.
I see. There's a very nice a question from a trainee in urogynecology. And they see LUTs with or without prolapse. And how to differentiate functional LUTs and neurogenic LUTs? That is a difficult question. As the same question is difficult to sometimes see if patients with Parkinson, who often are men in their older age, is their bladder problems, do they come from the prostate or from the bladder? So let's start with the women, since this is a question directly targeted at women. First of all, what you can do is do urodynamic with and without a PESAR in place. If the detrusor overactivity is still there even after you have reduced the prolapse, I would start treating the unless it's not a stage 4 prolapse, I would start treating OAB. And if it's possible, don't do urodynamic including the micturition, because often the urgency doesn't come during the filling phase, only when you tell them you can void now, then they can't hold it. And they often will tell you, you know, I leaked just before I reached the toilet. So, you know, since a surgical procedure can never be undone. And if there is a gynecology reason that you really have to treat this prolapse, then you should go along. But tell them that the urgency might not go away. And sometimes you have even de novo urgency after surgery. But if the surgical case is so severe that you have to do surgery, you have to do surgery. If not, try to first treat a detrusor overactivity with antimuscarinics. So, do we have other questions?
Yes, Professor, there is one more question from Dr. Abhay. Can you see?
I don't see and I don't hear.
Okay, he's asking about Abhay, what is your personal experience with the betanacol?
With nocturnal void?
No, with betanacol.
Yeah, it only helps when like after surgery if you have anesthesia. But I think the bladder would recover itself also without. Bettnachol. I misunderstood. It also doesn't work in diffuse overactivity. It reduces spasm in striated muscle, but not in smooth muscle.
He's asking the second question also that in his experience, it works only at the higher dose, about 200 to 200 milligram per day, I think, in hypnotic bladder.
I can't confirm.
So
and
that's
there are
all.
side and you have to consider the side effects.
So, any more questions from anyone? Those who want to ask. Okay, there is one more question come. Can you see, Professor?
Yeah. First of all, my question is: in patients, sometimes we offered a choice of treatment, or is the treatment always a single specific treatment option for each patient? That's a good question, especially in America. It seems everything possible, right? You have no sugar, no lactose, no everything but great taste. And but as it is in real life, sometimes you have options. And of course, like if you have an MS patient who has a much less risk to ruin their kidneys than the spinal cord injured patients. And she has a choice of going 10 times a day to the bathroom, or we would calm the bladder and maybe she has to do self-intermittent catheterization twice a day. That's the real choice. And I give this choice to the patients. Many patients say, I always tell them, if it gets too much in your nerves, if you see that it really harms your quality of life, if you don't dare to go into a movie theater, then you might consider reducing this urgency and increasing intermittent catheterization. And I can tell you, 6 weeks they're mad of me, and in the 7th week they say thank you, thank you, thank you. It takes a time to make this step, but I can hardly remember a patient who wants, you can just take the pills away and then start the old life again. Nobody returns. Once they have returned to intermittent catheterization and sufficient medication, they are hardly ever turned back, especially the woman with MS. And in the nice. I'm glad that somebody else has some side noises, not only me. And no, the thing is, in spinal cord injured patients, actually, you in the beginning shock them with the medication. You might even have a slightly worse quality of life. But I am the advocate of the kidneys. And the advocate of the kidney, for me, it's the advocate of the kidneys clearly says, the kidneys won't say, hi, I'm getting worse. So the kidneys have no voice. They don't, and if you see ultrasound dilatation, and if you see the values going down, the creatinine, and the creatinine is only a rough measure because the creatinine is very much dependent on your muscle mass. And of course, if you are a spinal cord injured patient, you lose all your leg muscles. So it takes a long while until your creatinine, compared to healthy people, is increased. And when it is increased, if the laboratory shows you a decrease in kidney function, as a roughly tool, 50% of your kidney function is already destroyed. So that's, in those patients, I don't give them a choice. I try hard to convince them. Of course, I can't force them. I'm not a policeman and I don't have a gun. But I really try my best to convince them, because in patients with high pressures, they really don't have an option. if they want to live longer than 7 years, they don't have an option. And sometimes I say it in this way. Because I understand, I mean, especially these veterans, I mean, they have so many psychologically and all other traumas, and sometimes it's not the only injury they have, and it's really hard. So I think you have to get additional help of a physiotherapist they know very well, who can teach them intermittent catheterization, a psychiatrist or somebody, or a good friend. So try to get additional help.
Yeah, it was very good answer, Prof. And yeah, it was very needed for the veterans here.
Yeah.
Okay, thank you. So anyone have more questions? So, okay. Okay. One more question came from Naveen. Can you see, Professor?
Yeah. What does, yes, you talked about Parkinson. Parkinson's disease is very difficult. Bladder dysfunction in Parkinson's is very, very difficult to treat because they are so sensitive to all side effects. And for them, I found that mirabegron they accept better because it's not targeting the receptors, the muscarinic receptors. But I don't understand this versus prostatism.
It was about the prostate gland, benign prostate hyperplasia.
Oh, prostatism. Oh, I know, I understand. Prostate. Yeah. Now I get it. Now, what's very difficult is if you have a patient with Parkinson and he has an enlarged prostate, and you see that they have a voiding problem, which part is due to the morbus Parkinson and which part is due to the prostate. And on the whole, I'd be very, very careful to do surgery on a prostate. I would always try to treat the prostate with medication first, because I've seen so many patients who then became totally incontinent because they have a rigid pelvic floor, and so they might have a combination of functional and organic intravesical obstruction. And if they have this MSA, then my clear advice is don't do any surgery, rather treat them with a catheter, then because they they leak. They can't hold anything. So that's why it's so difficult to treat elderly men with suspected BPO and Parkinson.